Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 18D, and which is Hematology, Malignant, Lymphoid, and Plasmacytic diseases. We are streaming live from AIIMS Bhubaneswar via Kolkata. A very important topic and a very renowned hematopathologist to talk on that topic. The topic of the day is hairy cell leukemia and large granular lymphocytic leukemia. And to talk on that, we have Dr. Somanath Padhi, who is an MD. Presently is an associate professor in the Department of Pathology and Laboratory Medicine, AIIMS Bhubaneswar, with 15 years of post-MD teaching. He is a life member of Indian Association of Hematology and Blood Transfusion, Indian Association of Pathology and Microbiology, and the reputed Indian Myeloma academic group. His areas of interest is hematopathology and lymphoreticular pathology, pathology of the bone marrow, plasma cell, myeloma, hemophagocytic, lymphohistiocytic syndromes, and leukemic cytogenetics. He has more than 50 publications in national and international index journals and has the honor of authoring 3 book chapters. Before I ask Dr. Somanath Padhi to start, let me request all of you to keep your mic muted, your camera off, and please do not share your screen. We are live on YouTube. Sir, please share your screen and let us start. Just press that arrow and yeah. Here, yeah, I can see your screen. Just please choose your PowerPoint and make it full screen. And press that hide thing. Yeah, fine, good to go. Thank you.
Thank you so much, Dr. Said Nadeem sir, for this wonderful opportunity. Professor Dr. Deepak Misra sir and my eminent mentors in Indian hematology as well as pathology, and for this giving this fantastic opportunities. First time in my life to present on an academic forum of such an important national and international repute. Before I start, I must say, wish you a very happy and prosperous New Year 2022, and to all of you, my esteemed teachers, my dear colleagues, presidents, clinical colleagues who are listening to me today. Thank you so much for joining. And before I start, I will say that I have selected this. This topic is of interest to me specifically. And since we all are living in this COVID era, so I thought of selecting a diagram of which is not really COVID, because COVID is also spiky, and we are today dealing with some cell which is also having a lot of spikes, but not spikes, that call as hairs on it. So this is what we're talking to on this hairy cell leukemia. And so I will be speaking on this following headings. Just I'll start with an historical perspective of this hairy cell leukemia. I'll introduce to this topic and what is the cellular origin of and the pathogenesis of this morphological changes in the lymphoid cells so that it becomes an hairy cell. What happens in the genetic level? What is the genomic alteration and pathobiology that is very characteristic of this such a wonderful disease that fascinate most of the hematopathologists and pathologists throughout, clinicians also. And the morphological approach that is most characteristic, most catchy, and that is even much more fascinating for us hematopathologists. The immunophenotypic characteristics keeps the morphologist at a bay. And what are these aberrances that keeps us in challenge, that pose a lot of challenges for this diagnostic challenges for us? The unusual presentations that can also be more interesting. What is the recent update and advances that is happening around in this hairy cell leukemia biology? And I will summarize before concluding. And then I will, of course, switch over to a topic on large granular lymphocytic leukemias. So I have decided that I will divide my topic to over a maximum 1 hour and 15 minutes. I think that will be fine for all of us. And so this journal, this was the first published paper on this entity, which was at that time it was called as leukemic reticuloendotheliosis. And since 1923, there are some scattered sporadic reports, but Edward was the first to describe this case of leukemia, which was characterized by hyperplasia of the reticulum tissues in the blood-forming organs, with the appearance of something called as reticuloendothelial cells in the bloodstream. And at the time, he termed this condition called as leucemia reticuloendotheliose, as other histiocytic leukemia, histioleucemia, reticulosis, malignant reticulosis, malignant leukemic reticulohistiocytes, and so many like things. But nowadays, this terminology has been obsolete, and this pioneer article was published in the issue of 1958, issue of July issue of Blood Journal, the Journal of Hematology at that time. And the authors in this paper, they described some 26 cases of this reticuloendotheliosis, with 21 males and 5 females, from the Department of Hematology at Ohio State University at United States over there during a period of 8 years, and with a detailed follow-up data. I have just summarized their presentation of this case, their series in 1958, and the most common presentations of the patients were generalized weakness and easy fatigability, which was most common. Almost all patients presented with that symptoms and signs. And splenomegaly was present in 96% of all these cases. And interestingly, this painful infarct, splenic infarcts, which was, and there was some episodes of exacerbation as well as relapse and remissions were also there. Spleen size was gradually increasing and decreasing. And 2 of the patients presented with hemoperitoneum because of splenic rupture, and there was 20% patient had hemorrhagic diathesis. They had cytopenias, which was more of an anemia, which is more common than leukopenia, as well as thrombocytopenia. Infection occurred in a significant proportion of nearly 58% of patients who had pneumonia, as well as a very high degree of fever, and 6 patients present with CUM-positive autoimmune hemolytic anemias. And what we are experiencing today was they also experienced long back, that 77%, 20 out of 26% of these cases, 20 out of 26 cases, they had a very difficult bone marrow aspirate, and the morphology, and these authors, they performed multiple and yet unsuccessful attempts from multiple anatomic sites to obtain a bone marrow aspirate and biopsy. They have tried from iliac crest, bilateral iliac crest, from the vertebral spine, from this anterior iliac spine, even from the sternum, multiple sites, but that was the unsuccessful. And they described something called as, at that time, was reticulum cells in the peripheral blood. So, and what they described was, this is what they call is a reticulum cell, and you can see that this is a supravital stain of the peripheral blood film, which was seen under phase contrast microscope. This two left-hand panels are phase contrast microscope, whereas the right-hand side is your scanning electron microscopy. And they also did the staining called as Janus green to demonstrate these mitochondria, which are knob-like structures around the nucleus, that black dots, which are inside the cytoplasm. And the authors described the cells, they have some sort of a lace-like cytoplasmic projections, and also had some sort of a vacuoles, cytoplasmic vacuoles. Nucleus was eccentrically placed, which has a spongy nuclear chromatin. They have a smooth, distinct nuclear membrane, not much conspicuous nucleoli. And on scanning electron microscopy, it was what they said, that some pseudopod-like projections, cytoplasmic projections, and which was also very much highlighting this knob-like perinuclear distribution of this mitochondria. And this is, and they call this term, they use the term called as reticulum cells. So, what exactly is this hairy cell leukemia? This hairy cell leukemia is which was reticuloendotheliosis of the past, is now hairy cell leukemia. Is a distinct but rare, low-grade chronic lymphoproliferative neoplasm of mature and post-germinal center B lymphoid cells, generally involving this bone marrow, peripheral blood, and spleen. And this, the characteristic triad of this presentation of this hairy cell leukemia is pancytopenia, which is in presence of an hypercellular but yet a fibrotic bone marrow. And there is also presence of splenomegaly, which is a characteristic sign of this disease. This disease comprises 2 to 3% of all lymphoid leukemias, and there is a more of a male predominance both in Asian as well as Western population. Data is same. It is more common in the Caucasians and then this Asian population, and this population in Western countries is around 0.3 to per 1 lakh population in things. Whereas though we do not have an exact data the prevalence of same in this Indian subcontinent, but the three major institutes of India like CMC Vellore has reported 79 cases in 16 years from 2001 to 17. AIIMS New Delhi had some 35 cases in 12 years, 2002 to 14, and PGI Chandigarh reported some 21 cases in 5 years. So roughly 3 to 4 cases per year. That is the incidence rate in Indian scenarios. What exactly is the cell of origin? Actually, there is no clear-cut answer to this. That's we do not know what is the normal counterpart of a hairy cell. But it is postulated that is possibly the late activated germinal center cells, the late the terminal stages of differentiation before the formation of plasma cells. They are the post-germinal center memory B cells, and sometimes even the splenic marginal zone B cells are supposed to be these originating cells of the hairy cells. But paradoxically, even if it is called as splenic marginal zone, which is normally located in this white pulp, but this hairy cells that typically involved or dominantly involve the splenic red pulp and with an atrophy of the white pulp. And also to add to this, the evidence that supports this theory of post-germinal center origin is the DNA methylation and mutation profiling of immunoglobulin heavy chain studies have supported that they are most likely from the post-germinal center origins. Now, how does a post-germinal center memory B cell becomes a hairy cell? What happens? There is that we all know this is what is the landmark paper that was published in New England Journal of Medicine in 2011, and that said that this is the chromosome number 7. We also know that this is chromosome 7, and this is the long arm of chromosome 7, and there is something called as 7q34. This is chromosome 7 long arm band 3 zone 4. That is the zone for what is known as BRAF proto-oncogene. So BRAF is a proto-oncogene, and so there occurs a somatic mutation at the exon 15 and at the position of 1799. And what it leads to is there is something called as exchange between two nucleotides. The thymine is exchanged with adenine, and as a result of this valine is substituted by glutamic acid, and at the codon 600 of BRAF messenger RNA protein. And that's why nowadays we call them as V600E. Okay, so this is the molecular event, and this leads to something called as constitutive activation of BRAF by autophosphorylation. Similarly, that receptor tyrosine kinase in activities that leads to an autophosphorylation. So the main pathway of following this autophosphorylation is there is a downstream activation of MIKEY ERK signaling pathways, and this leads to something called as increased expression and survival advantage pathways that leads to increased survival and proliferation by ETS family, FOS and MYC's upregulation, decreased apoptosis, and that produces what is known as the clonality, that keeps the clonality and this clonal expansion of this mature B lymphoid cells. Now, so arguably this BRAF's B600E mutation is considered the molecular hallmark in hairy cell leukemia, but up to 10 to 20% of patients with this hairy cell leukemia may have this, there is no mutation of this BRAF gene. This is known as BRAF wild type, that is known as BRAF WT. And when this is seen, it is usually maybe most likely because of this mutation in the exon 11 rather than exon 15, and this must be ruled out. And several studies have now come up with the data that BRAF wild type hairy cell leukemia is an heterogeneous subgroup of hairy cell leukemia with a distinctly poor prognosis, refractiveness to therapy, and an inferior outcome. And it is also important that since the BRAF is implicated in this pathogenesis of this hairy cell leukemia, and we all know that BRAF pathway is also implicated in so many solid tumors like melanomas, carcinoma of the lungs, ovary, bladder, and thyroid, prostate, as well as gastrointestinal stromal tumors. And also up to less than 5% of cases of chronic lymphocytic leukemia, small lymphocytic lymphoma, even multiple myeloma may also harbor this BRAF mutation pathways. So why I'm highlighting this point is that because because these patients with hairy cell leukemia, because they are indolent neoplasms, there are many drugs which are available which prolongs the survival of this hairy cell leukemia patients' the outcome. However, at the same time, these hairy cell leukemia patients are at increased risk of development of many second primary malignancies, and notably most common of this is malignancy of the skin cancer like squamous cell carcinoma, melanomas, bladder cancers also. So and that's why it is not uncommon to also to have a coexistence of CLL, SLL along with hairy cell leukemia. Even myeloma can be associated with hairy cell leukemia also. So these all because of this implication of this BRAF and MAP-RK pathway activates. Now, so this table by this the beautiful review of in American Journal of Hematology, which has come in September 2021 by Trossard et al., that shows that this BRAF pathway is implicated in up to 70 to 100% cases of hairy cell leukemias. Never seen in hairy cell leukemia variant, splenic diffuse red pulse lymphoma, splenic marginal zone lymphomas, whereas this hairy cell leukemia variant and is associated with a pathway called as MAP2 kinase pathway implication, and that gives an inferior prognosis and refractiveness to therapy in hairy cell leukemia variants. Whereas splenic diffuse red pulse lymphoma may also harbor this MAP2 kinase pathways abnormalities in up to 12% of cases. Cell cycle regulators pathway like cyclin dependent kinase protein pathways, even CCND3 pathways are also implicated in some cases of up to 16% cases of this hairy cell leukemias, rarely with variants as well as all the other mimics of hairy cell leukemia. And this is interesting to note that because this pathway of cyclin dependent kinase and cyclin dependent gene pathway is also probably one of the reasons why that some significant subset of hairy cell leukemia also express cyclin D1, and that gives a confusion which I will be highlighting in my later parts of the slides. This downregulation of T53 is up to 28% and up to 38% cases of hairy cell leukemia variants are seen. Epigenetic alteration like DNA or methylation pathways are also implicated to a very high proportion of patients with hairy cell leukemia variants. And Notch pathway and B-core pathway are also some of these secondary pathways which are also implicated, but more common in the mimics of hairy cell leukemia rather than in hairy cell leukemias. Now, this diagram tells us the most of this pathophysiologic pathway of what hairy cell does. A post-germinal center memory B cells once because of somatic hypermutation and this BRAF activation, once it becomes the hairy cell. This is what is a typical hairy cell, and what it does is that this hairy cells express something called as this B cell receptor. Of course, that will be because this is a B cell neoplasm, that is fine. But it also expresses something called as chemokines. The chemokines CXCR4 as well as CXCL12, which are also implicated, and this stimulates the BTK and PKC beta pathways and all these chemokines. And also, this another interesting part is that these hairy cells, they express a lot of integrin molecules. Integrin alpha 4 beta 1 is known as VLF4, and integrin alpha B beta 3 or CD51. And these integrins are essential for these three important reasons. These integrins, they play a vital role in this homing mechanism of these hairy cells to the bone marrow, because these integrins, they bind to this fibronectin and vitronectin in this bone marrow stromal microenvironment. that helps these cells to reside inside the bone marrow environment. Extracellular matrix interaction is essential because of these integrins. These integrins are also they bind to the something called as V-camp adhesion molecules, and they also bind, which are expressed in the bone marrow stromal cells. And these also have a strong affinity towards endothelial cells because of these interactions. Similar to these myeloma cells, they always love to have a lot of interactions with this bone marrow stromal microenvironment. So these hairy cells also, they reside in a very perfect conducive bone marrow stromal microenvironment. And also these hairy cells, they bind this also express CD40, which binds to CD40 ligand on the T cells. And as a result of this, the host tumor immunity is suppressed. So that in one way, these hairy cells, they inhibit this T cell mediated host immune attack against the hairy cells. So that prevents them for their supports their survival. These chemokines, the interesting part of this chemokines CXCR4 and CXCL2 is that these two chemokines, which are mostly expressed by these hairy cells, are not expressed much in the lymph nodes. And that is the reason why these hairy cells, they do not prefer to they cannot go to the lymph node, or they home to the lymph node. That's why we do not usually find a significant lymphadenopathy as a presentation of hairy cell leukemias like other lymphoproliferative neoplasms. And also it is important to note that there is presence of these two molecules which are known as transforming growth factor beta 1 and fibroblastic growth factor 2, that's known as basic fibroblastic growth factor. These are released by this in an autocrine fashion, and that is the most important cause of what is known as pericellular reticulin fibrosis, which is so characteristic of an hairy cell leukemia refined morphology. That's why we, as a hematopathologist, we rarely require a Masson trichome stain to demonstrate the this fibrosis of the marrow, because the fibrosis in the marrow in a hairy cell leukemia is always a pericellular fibrosis rather than a collagenous fibrosis. Whereas the similar thing was Masson trichome will be more useful when we expect like a collagenous fibrosis, like in a case of primary myelofibrosis or with secondary myelofibrosis of other CM myeloproliferative neoplasms. So this is the utility. That's why this reticulin fibrosis is because of this transforming growth factor beta 1 and basic fibroblastic growth factors. And you can see that here this receptor tyrosine kinase activities, this autodimerization that activates RAS pathways, BRAF, MEK, ERK pathways in the left hand side in blue, and that's why the BRAF inhibitors are nowadays useful for this, like vemurafenib and dapagliflozin. All these are there for this pathways inhibitors. There are also something called as MEK inhibitors like trametinib and cometinib. Whereas in the BTK, which is highlighted in the right hand side, you can see that this BTK inhibitors, which is ibrutinib, acalabrutinib, and zanabrutinib, all these are these drugs which are now these things. So basically, it is both primary hit is the BRAF mutation in the post-germinal center memory B cells, which leads to secondary event of something called as genetic and epigenetic alterations, and is a lot of beautiful and well coordinated interactions between the lot of cytokines and with the stromal microenvironment. This is what is the main basis for all the morphological aspects that we are going to see later on. Now, it is also interesting that we always say that why some cells in this peripheral blood or aspirates, why these cells they form a hair-like projections. This is just I have taken this from this just to highlight that this is just a fluorescent. This is nothing, just to highlight that this is a lot of hair-like projections. Circumferential is not, in contrast to something called as in a polar villous projections of splenic lymphoma with villous lymphocytes or splenic marginal zone lymphoma with villous lymphocytes. They have a polar one side polar projections, whereas this is known as circumferential hair-like projections. So what exactly is the cause of these projections? Why hair cell morphology? So this BRAF V600E mutation pathway, and that leads to this lot of intracytoplasmic changes. There is overexpression of cytoskeletal components such as actins, intracellular phosphoproteins, members of the Rho family of small GTPase involved in active cytoskeleton organizations. All this accumulates and inside the cytoplasm, and that gives to like this type what this 1958 blood article said that there is something called as lace-like cytoplasmic projections, and that was also proven by the electron microscopic evidences. The more evidence is that why this is that because it's in vitro, when these hairy cells, they're exposed to this BRAF inhibitors. So what exactly happens is there is again marked dephosphorylation occurs in downstream pathways, and that leads to a silencing of this RAS, RAP, MEK, ERK pathways, and loss of this HCL, this hairy cell leukemia specific gene expression profile signature happens, and that reverses the morphology of the hair cell to just a smooth muscle cells. This is in vitro studies, and that leads to more quick apoptosis. So all these findings of in vitro studies supports that it is because of this accumulation of all these filaments and different molecules that gives rise to what is known as a hairy cell morphology. Also, the possible accumulation of this beta-catenin, intracytoplasmic beta-catenin also possibly is implicated as a cause of this hairy cell morphology. Now, with all these backgrounds of the hairy cells, as a pathologist, hematologist, hematopathologist, we are more fascinated to see under microscope. Okay, this diagram that is I have taken from the International Journal of Lab Hematology 2018 that beautifully depicts the diverse population of the lymphoid cells that can be seen in a peripheral smear, which we need to always examine with utmost meticulousness. Okay, peripheral smear is the cheapest, it is the most vital part of a hematological evaluation, and it forms the bread and butter also. So as you can all see here that in the left hand, the first panel is this left hand corner is a normal mature small lymphocyte, which is a normal component, and similar size or maybe slightly increased of same morphology is the chronic lymphocytic leukemia cells, CLL cell, and you can see the right hand side is the kind of splenic marginal zone lymphoma, where you can see that in only one direction there are some sort of bulbous villus like projections, pili-like projections of splenic marginal zone lymphoma with villus lymphocytes, whereas this mantle cell lymphoma cells can have a diverse morphological appearance. They can be mature lymphocytic-like, they can have a nucleus with a grooved nuclei with a mature morphological look, or they can even have a blastered look of inappropriate age. Whereas the classical center one in the second row is the typical circumferential fine hair-like projections of hairy cells. Follicular lymphoma, as we all know, that presents with a deep indented centrocyte like known as buttock cells in the peripheral smear, and the prolymphocytes, they are larger cells which are having a moderate to abundant amphiphilic cytoplasm, and they have a single central nucleolus, which is a case of the prolymphocyte, and which are seen in a case of CLL or CLL in progress into CLL-PL or prolymphocytes. This middle one in the third panel is this large granular lymphocytes, T granular lymphocytes, which I am going to discuss more in the latter part of my talk. And the typical deeply indented cerebriform appearance of the nuclei with moderate cytoplasm is the typical Sézary cell. And the blast cells of acute lymphoblastic lymphoma leukemias are high in-biopsy ratio, multiple nucleoli, all these things. The plasma cells rarely seen in the peripheral smear, but of course, when in case of multiple myeloma, there can be spillage of plasma cells, or in the case of plasma cell leukemia, we can see these plasma cells. And the last but not the least is the right lower corner, the cell of known as the virusites or the activated or the reactive lymphocytes of infectious mononucleosis. So all these features are why I'm talking about this is that of all these things, of all these lymphocytes in the peripheral smear, only two lymphoid cells, which one is splenic marginal zone lymphoma with villus lymphocyte and a hairy cell leukemia. These two lymphocytes in peripheral smear is associated with a significant splenomegaly. Hairy cell leukemia and splenic marginal zone lymphoma typically we expect a significant splenomegaly as an important clinical sign. We must not forget this clinical sign while interpreting a peripheral smear also. Whereas CLL patients may have it may be absolutely asymptomatic, but typically presents with lymphadenopathy. Splenomegaly can be seen, but not necessarily. Mantle cell lymphoma, this follicular lymphoma, they present with bulky abdominal lymph nodes, epitrochlear lymph nodes, cervical lymphadenopathy that dominates the clinical presentation than a spleen. Whereas Sézary syndrome is mostly characteristic is there should be some cutaneous lesions, erythroderma, nodular lesions, psoriasiform lesions, licheniform lesions that dominates the picture. Whereas plasma cell leukemia is, we all know that these plasma cells are, because of the CRAB criteria, all those features we need to correlate, and this pro-lymphocytic as a part. So we must understand that splenomegaly is present in two important conditions of hairy cell and splenic marginal zone lymphomas. And but splenic marginal zone lymphomas are usually present, they are not cytopenic, rather they present with leukocytosis, with absolute lymphocytosis, whereas hairy cell leukemia presents with cytopenia. Now, though we are very much fascinated to see what is a classical hairy cell, but it is also important to note that if we are lucky enough, if our preparation, the smear preparation, staining, everything is perfect, we may appreciate, and if we are not very much alert, we may even miss this hairy cells. Though hairy cells, circulating hairy cells are seen in up to 95% of cases of classical hairy cell leukemia, but it may be also missed also to an inexperienced or even an experienced person because of the different lab related staining issues, all these things, we may not find these things. But so that's why it is the international consensus is that the bone marrow triphyine morphology is always very much characteristic and very much useful in assessing the burden of disease and depicting the typical morphology. And as we all know that bone marrow aspirate is also most of the times it is a typical aspirate, scant, hemodiluted. And if you are lucky enough, that aspirate may be useful for flow cytometry also. But this is what is the left hand side. This is one of our classical cases. You can see the typical diffuse pattern of infiltrate of a small to intermediate size lymphoid cells, which are widely spaced. They have a distinct cell border. They have moderate to abundant amount of cytoplasm, central to eccentric, round to slightly indented nucleus, smooth nuclear contour, no nucleolus, no large cell transformation. This gives a typical fried egg appearance. You can see that this is the fried egg central, and that egg yolk and surrounded by this white. This is typical fried egg appearance, and that produces that reticulin, extensive reticulin fibrosis. And this is what is an annexin A1, which is the most specific immunohistochemical marker to demonstrate the presence of this hairy cells. So this is a classical presentation of an hairy cell leukemia on triphyine biopsy. But the key message I would like to highlight that from the key message that we should not forget from the triphyine immunohistochemistry in hairy cell leukemia is that annexin A1 is the most specific marker of hairy cells. Okay, this is not expressed in any other B cell lymphoma other than hairy cell leukemia. And it is, and if something which is neoplastic, which is annexin A1 positive, that means it is hairy cell leukemia, not any mimics of hairy cell, like variant hairy cell is ruled out, splenic marginal zone lymphoma is ruled out, and splenic diffuse red pulp lymphoma is also ruled out. So that is the significance of any tricky situations. If a flow cytometry, when it's not very conclusive, there is a confusing or something we'll discuss now, that the triphyine immunohistochemistry with annexin A1 in a CD20 positive lymphoid infiltrate is sufficient, and it confirms the diagnosis that it is hairy cell leukemia. However, it is also important to remember that annexin A1 has a lot of internal controls in the bone marrow triphyine. This is expressed in maturing myeloid cells as well as subset of T lymphocytes. That's why interpretation of annexin A1 requires in presence of a CD20 positive cells. So no one should interpret annexin A1 positivity in the absence of CD20 immunohistochemistry markers. Those CD20 positive cells should be interpreted whether they are annexin A1 positive or they are not positive. And this is the reason. This when a person of hairy cell leukemia undergoes therapy, and if clinical hematologist wants to assess this the minimal residual disease status of a case of hairy cell leukemia, annexin A1 is not the recommended immunohistochemical marker because of this presence of so many internal controls which maybe give a false positivity. And in presence of this, that's why it is said that it is the flow cytometry or immunohistochemistry with another specific marker known as TBX21, or even nowadays even this BRAF V600E mutant immunohistochemistry is also available. That any of these three can be used to assess the residual disease status in the case of post therapy. Now, after this immunohistochemical characteristics, let's start with what is known as the immunophenotypic features, the signatures of classic hairy cell leukemia. In 1994, this article was there published in Leukemia Lymphoma that by this Matthews, this is known as Matthews scoring system. This immunophenotypic of hairy cell leukemia, they proposed this group Matthews et al. They proposed a scoring system to distinguish hairy cell leukemia from other B-cell disorders with a hairy or villous lymphocytes. They took 194 patients with a B-cell disorders, of which 69 had typical hairy cell, 25 had hairy cell variant, and 100 had some splenic lymphoma with villous lymphocytes. And after a lot of permutation and combination and flow cytometric intensity and median fluorescence intensity comparison, they found that four important markers. Okay, four important markers like CD11C, CD103, CD123, and CD25. These four markers, they were assigned 1 point for each marker positivity on flow cytometry. And so total score of 4 or 3 or 4 is always seen, is very classical of hairy cell leukemia, which is seen in up to 98% of cases. Whereas the hairy cell mimickers, that means B-cell leukemias, lymphomas with villus-like or hair-like morphology had like variants or other things had a score of maybe they are all negative for this either of these four markers, or maximum total score is 2. So we strongly propose that if we have a immunophenotyping by flow cytometry, be it in flow or in all these four markers are also available in IHC also. So either of these conditions, if we find this four marker positivity, we should always try to go assess the total score. Two substances that this is he is well known to most of us, Dr. Prashant Timbare from Tata Memorial Hospital, Parel, Mumbai. His article in 2011 Leukemia Lymphoma that he has given a very nice elaboration and elucidation of a normal as well as this diagnostic approach of a flow cytometry by this of these hairy cells. So these are what is a normal. This is a normal B cells. You can all see that normal B cells are CD20 positive, CD22 positive, CD103 negative, 11C is heterogeneous to negative, and CD20 is positive, CD25 negative. These are normal B cells are CD25 negative because CD25 is an T cell marker. This is a regulated T cell marker which is expressed in this hairy cells. CD20 and 123 is negative. So this is 103 negative, 11C negative, 25 negative, and 123 negative. This is normal B cells. Whereas in comparison, this hairy cell leukemias, they are 20 and 22. Of course, they are negative, they are positive because they are B cells, but they are strongly positive for CD103, CD11C, CD25, as well as CD123. That means all the four markers are positive, so total score is 4. Hence, the diagnosis of hairy cell leukemia is confirmed with 100% specificity. And in contrast, a hairy cell leukemia variant has 103 is positive, 11C is positive, but 103 is not, it's like a plus minus type. CD25 is negative, whereas CD123 is negative. So it gives a score of just 1 only. So it is not hairy cell leukemia, it is a hairy cell leukemia variant. And last but not the least, it is the splenic lymphoma villus lymphocyte, which is positive for CD20 and CD22. 103 is negative, 11C is also heterogeneous, and so 25 is negative, 123 is negative. So all these things are, and there are some studies which says that splenic marginal zone lymphoma, they express CD11C, CD22, CD76, CD38, and CD27. And these markers are expression by splenic marginal zone lymphoma is useful for differentiating it from splenic red pulp lymphoma. Now, coming to this next to substances, this further these things that this article this in cytometry B clinical cytometry 2019 paper that by this Salem et al. And they have compared 58 hairy cell leukemia patients with 25 hairy cell leukemia variant cases, And what they have found is that they have compared the median fluorescence intensity by flow cytometry between these two subgroups. And you can see that in the box plot diagram, you can see that there is CD43 is strongly expressed. This median intensity of this CD43 is significantly higher than variant hairy cell. Whereas the CD81 is more stronger expression of CD81 is seen in hairy cell leukemia variant. CD81 is almost negative in hairy cell leukemia, or they're just very weak expression. Similarly, CD79B is a very higher intensity in a hairy cell classical, whereas a heterogeneous wide expression range of CD79B from almost 400 to a wide range of in hairy cell variant leukemia. And CD200 has the very high median fluorescence intensity in classic hairy cell leukemia, whereas this is low or negative or weak in a case of variant leukemia. This is the comparison, and this is the corroborative scatter plot diagrams of the both. In the upper row is a classical hairy cell leukemia. The lower row is what is your lower panel is hairy cell leukemia variant. The green ones are the T lymphocytes. These purple ones are the residual B lymphocytes, and the cells of interest are this red population, which is CD19 positive, strong CD43 positive, the classical hairy cells, whereas CD43 is very weak in variant hairy cell. CD81 is almost negative in a case of classical hairy cells, very strong expression in a variant hairy cell. 79B is strong expression in a case of classical hairy cell, negative in a case of variant hairy cell. And CD200 has a very strong expression, or you can say that bright expression in a case of classical hairy cell, and it is negative in a case of variant hairy cell. So this diagram, this table is there in most of the textbooks, journals, everything. This again from the cytometry journal 2014. And among all CLPDs, chronic lymphoproliferative neoplasms, CLL, mantle cell lymphoma, follicular lymphoma, marginal zone lymphomas, hairy cell variants, Waldenstrom's lymphoplasmacytic lymphoma, B pro-lymphocytic leukemias. Among all these low-grade lymphoproliferative neoplasms, hairy cell leukemia has the highest degree of CD20 expression. Most bright expression of CD200 is seen in a case of hairy cell leukemia. And also, it is also important to note that if we are finding that CD38 expression is seen in a case of hairy cell leukemic cells, that gives an worst prognostic outcomes. So CD38 expression should also be carefully located there, because many tubes may have centers, they also may have to rule to this lymphoplasmacytic lymphoma. CD38 may be there. So if hairy cell leukemia cells that are expressing CD38, that means that this gives a protection against apoptosis. That means this is a survival advantage, and it is a marker of poor prognosis. Now, these are the all common, after we all know that the classical presentation of hairy cells and this morphology is these things, but classical things are not always classical. We always do not come across with classical presentations. So this, we begin with something called as immunophenotypic variations in the case of hairy cell leukemia. This original article in American Journal of Clinical Pathology 2006. And let me just go through with that some cases, interesting cases. This a case of hairy cell leukemia, this CD19 gated population, CD19 which is positive for CD20 as well. They are lambda lights and restricted. CD103 is negative in this case. Very nice expression of CD11C as well as CD25. So this is a classic case of hairy cell leukemia with a total score of 3, because CD103 is negative. So this is a case of CD103 negative classic hairy cell leukemia. And this second one is 103 positive, 19 positive, 11C is positive, and 19 positive, 25 positive, but there is a strong expression of CD23, which is normally not described in a case of hairy cell leukemia. So there is an aberrant expression of CD23, which is seen in this particular case of classic score 4, immunological score 4 hairy cell leukemia, CD23 co-expression. And this is the third panel that shows that 103 is positive, 19 positive, 11C is positive, 25 is positive, and there is a co-expression of CD10. Okay, so there is a CD10 which is also being co-expressed, and that might create a confusion in a classical case of hairy cell leukemia. And this last, the fourth photograph, we can see here that there is a 103 and CD19 gated population, 103 positive, 11C strong positive, and CD25 is negative. So this is a CD25 negative classical hairy cell leukemia, and these authors have reviewed this the 12 cases of with different aspirate specimens from the bone marrow, peripheral blood, and splenic aspirates as well. Many were lambda lights and restricted, and there was only one case, as I saw in the left hand panel, was CD25 negative. 11C was expressed uniformly in all cases. That's why CD11C as well as CD103 are considered as screening markers for a hairy cell leukemia. Okay, CD11C and CD103 are considered as screening markers of hairy cell leukemia. If you want to do that, some of the cells are positive for these things. So first thing is, so in be it in IHC, that has to be 11C has to be there, 103 also should be there, and same also is in the case of flow cytometry. But what was most interesting in this case was not a single case showed any aberrant expression of CD5. There was no expression of CD5, whereas a significantly higher proportion of patients with 95% of cells, 82% had this CD10 expression as well as CD23 expression. So the literature says that this CD10, CD23 co-expression in a classical hairy cell may be seen in up to 20% of cases of classical hairy cell leukemias, whereas the CD5 expression is seen in up to 2 to 3% of cases, what the Western data suggest. Whereas this interesting case report with a systematic, with a proper review of all the case things by this Dharmendra Jain from All India Institute of Medical Sciences, New Delhi, and they have described a case of CD5 positive hairy cell leukemia with a review of 26 cases reported till 2016. This article was published in 2016, and what they have reviewed that at that time they did most of the cases they did not have this annexin A1 immunohistochemistry that refined. But what was more interesting to note was that this CD5 positivity cells, these 26 cases, including and this 27 cases of this CD5 positive hairy cell leukemias, they have a variable expression, or there is lack of CD103, 123 as well as 11C, even 25, and many were associated with variant hairy cell phenotype rather than a classical phenotype. So the authors postulated at that time that the positivity of CD5 in a hairy cell phenotype cells is more commonly or more likely to be associated with a hairy cell variant as compared to classical hairy cell. But there are some studies which are also coming up. This might also be linked to this lack of loss of CD103 or 123, or this may have some underlying different mutational status, and that may confirm a survival advantage or a poor prognostic outcomes in a case with CD5 positive hairy cell leukemias. And this is another interesting from the Prasant Timbari et al. From the TMS Mumbai, and they have seen that 4 different cases of CD5 positive. The first panel, you can see that this first panel row, last one, CD5 positive cells which are gated against CD19. The second one is this. So all these are different sporadic cases of CD5 positivity in a case of hairy cell leukemia, that creates a lot of confusion, that in interpretation. And this is from All India Institute of Medical Sciences, Bhubaneswar, our own group. We have this was a 69-year-old male patient who had severe fatigue and generalized weakness. He had no evidence of any hepatosplenomegaly. He had severe pancytopenia, but on chest X-ray there was a mediastinal widening and there was a mediastinal mass, mediastinal lymph node. And for that reason, that was compressing this major bronchi, for which he had some issue of breathlessness, and for which he was actually admitted into the pulmonary medicine. But because of the pancytopenia, he was referred to the clinical hematology of our institute, and we evaluated the patient for this pancytopenia. But as I have already said, that this patient had a pancytopenia with relative lymphocyte predominance, and hardly any of the lymphoid cells were typical or classical hairy cells. With a very meticulous look of the under microscope, we could appreciate some very fine eyelash-like some sort of cytoplasmic projections in the lower panel. But none of these lymphoid cells had a classical hairy cell morphology. But we can also see that there are some teardrops in the peripheral smear. So we never suspected that this could be a case of something, which just thought possibility we are looking at a case of an aplastic anemia. But when you did a bone marrow tryphin aspirate, the aspirate was a dried up. That raised a suspicion against hairy cell leukemia, aplastic anemia. And the tryphin biopsy shows there is a diffuse infiltrate of this typical cells with a typical fried egg appearance, and which was strong CD20 positive, and annexin A1 was also strongly positive. But what was also, because we did also a CLPD panel, and in that we also saw a very significant strong expression of CD10 as well in this case. So that had a doubt. But and also when you did a flow cytometry of this case from the whatever aspirate we did, repeat bone marrow aspirate, we had strong CD123 expression, CD25 expression, CD11 expression, 103 expression. So score is 4. So it is a classic hairy cell leukemia. Also, it has a strong CD200 expression, but also there was a heterogeneous expression subset was also CD23 positive. So this particular case had unusual presentation, mediastinal lymphadenopathy, and had a aplastic-like differential diagnosis. So we reviewed the literature of such type of unusual presentations in hairy cell leukemias. We reviewed 10 cases at that time in 2020. And what was more interesting to note that most of the cases, there was hardly any evidence of an hairy cell in the peripheral blood. There was absolutely, or very occasionally, there were very, with lot of difficulty, the authors have suggested there were circulating hairy cells. Percentage of hairy cells were very less. But all had a very dry tap. They, on the tryphin biopsy of majority of the cases, had a aplastic anemia-like morphology. Excuse me. But there was infrequent splenomegaly. There was lymphadenopathy was also seen. Some of the cases had also occurred in the breast, skull base, as well as presented with pathological fracture. Skeletal lesions were there. Hairy cell morphology in the PS was uncommon, but bone marrow tryphin showed focal fried egg appearance, not diffuse, and there was reticulin fibrosis. And there was also there was a lot of cases with aberrant immunophenotypic expression. So this is another interesting aspect of hairy cell leukemia. This recently we published in Indian Journal of Medical and Pediatric Oncology of our 7 cases of in the last 5 years, which were annexin A1 positive proven and the classical morphology of fried egg appearance, and we can appreciate that there is a presence of cyclin D1 positivity in 2 of the 7 cases. And cyclin D1 expression in hairy cell leukemia is, we reviewed the literature that cyclin D1 expression in hairy cell leukemia is heterogeneous, that is weak to intermediate in intensity, in contrast to strong nuclear positivity of cyclin D1 in the case of mantle cell lymphoma. And that's why we always we suggest that whenever we explain presence of, especially when aberrant immunophenotype of CD5 positivity, if cyclin D1 comes positive, that may, especially in an extramedullary site of hairy cell, that may give a suspicion of a mantle cell lymphoma involvement rather than a hairy cell things. So in these cases, the cyclin D1 positivity must be correlated with SOX11 immunoexpression, or if necessary, we also should go for CCN-D1 fusion studies and BRAF V600C mutation analysis. And some say there are also sporadic reports of that atypical presentation of this hairy cell leukemia with a lymphadenopathy, strong cyclin D1 expression, which was and CD5 positivity, which was misdiagnosed as mantle cell lymphoma and treated with R-CHOP chemotherapy and without any response, and after persistence of disease, and there is a disease relapse. So at the time of relapse, again the evaluation which with a BRAF mutation analysis confirmed that it is actually a cyclin D1 expressing CD5 co-expressing mantle hairy cell leukemia, and following which the patient was treated on cladribine infusion therapy with a proper good response. So cyclin D1 positive CD5 co-expressing hairy cell leukemia is a subset of a special variant of hairy cell leukemia, which might create a lot of diagnostic confusion, especially when the presentation of hairy cell diagnosis is atypical or the hairy cell leukemia involves the extramedullary sites like skull base, paravertebral, all those things, paravertebral masses. But at the same time, cyclin D1, if it is positive in a confirmed case of hairy cell leukemia, that also is a useful clue to differentiate against others and low-grade B-cell lymphoproliferative neoplasm like splenic marginal zone lymphoma, hairy cell leukemia variant, which normally they do not express cyclin D1. There is no report of such things expression in a marginal zone lymphoma. So while we're talking about the classical presentations, classical immunophenotyping, classical presentations with aberrant immunophenotypic expressions, we should not forget that this hairy cell leukemia is notorious for its diverse clinical presentation, very atypical and unusual presentations like bulky abdominal lymphadenopathy. Okay, mediastinal mass, as was in the previous, in our case, there may be paravertebral masses presenting as paraplasia. Body cavity effusion is not uncommonly reported. They are also seen. Skin lesions are very commonly seen in patients with hairy cell leukemia. These patients, hairy cell leukemia can have an oculocorneal involvement with retinal artery thrombosis. That is unusual presentation of hairy cell leukemia. Neurological meningeal compression because of some mass lesions in this meninges, like a chloroma type. They can have a esophageal gastric hepatic involvement, though is expected, but esophageal gastric involvement can have and also skeletal lesions. So all these things we should also keep in mind, especially when we come across a patient with this type of things. So we need a proper and team-based approach for both clinical, radiological, and pathological, hematological approach to reach at an accurate diagnosis, as well as molecular pathology is essential for the final diagnosis. So, to add to this spice of this unusuality of this hairy cell leukemia behavior, this series of 13 cases, that is of 13 cases of hairy cell leukemia and extranodal sites, in extramedullary sites involving the node. The nodal presentation, dominant nodal presentation, 10 cases, and extranodal in 3 cases of hairy cell leukemia over a 30-year periods. And all these patients were known cases of hairy cell leukemia, which were confirmed cases of hairy cell leukemia, diagnosed from peripheral blood and bone marrow evaluation, flow cytometry, immunohistochemistry, whatever. And there was a significant lag of this presentation. The median gap on the presentation of this lymphadenopathy was 35.8 months after the diagnosis of hairy cell leukemia. And they have a very peculiar pattern, because in similar to this bone marrow tryphin, they have a more of a diffuse pattern of involvement of the lymph nodes. Sinusoidal, as is expected, is because of this affinity towards the blood vessels, these hairy cells. They have a sinusoidal involvement was there in 25%, but also interestingly 13% cases had a nodular pattern of lymph node involvement. Nodular pattern of involvement in a tryphin as well as in extranodal site is distinctly unusual, and that is a cause of a morphological challenge, because usually hairy cell leukemia doesn't present with a nodularity of nodular lymphoid aggregates. It is not coming under a differential diagnosis of a nodular lymphoid aggregate in a tryphin biopsy. It usually presents with interstitial or a diffuse infiltrate rather than a nodular. But when it comes as a nodular presentation, that creates a problem. It mimics like other lymphomas rather than. However, the morphology in the lymph node were mostly of a pyritic appearance. Some had a plasma-sided appearance. But the nodal as well as external disease had a overlapping immunophenotypical profile of other B-cell neoplasms, which included, there is a strong expression of cyclin D1 in 70% of these cases. 70% out of this 13 cases had cyclin D1 expression, CD43 expression, CD10 was seen in 38% of these cases, and 8% cases had also coexistence of CD5 expression. So that created a lot of confusion for that it is possibly a case of mantles and cyclin D1 overlap. So, and the authors, they described when that concluded that this CD43, CD10, all these co-expressions, aberrant immunophenotypic expressions, which are more rarely described in leukemic hairy cell leukemia, is much more common in extramedullary sites. And all these cases of immunophenotypic aberrances must be correlated with the BRAF V600E mutation status to reach at a confirmatory diagnosis. And when in case of any doubt, there is something called, now we have CD103 is available, 11C is also available, that we can try to say that at least, okay, we are probably looking at a case of hairy cell leukemia with an unusual presentation. So this interesting article in Lancet Oncology 2019, that this was an elderly male who presented with multifocal osteolytic lytic lesions involving the pelvic bones, the sacrum, presenting with a painful multifocal osteolytic lytic lesions, and on evaluation he had a hyper gamma globulinemia, and when PET CT was done, there was a destructive bilateral osteolytic lesions with marked metabolic activities. And you can see that in the left hand side there is also extra cortical extension, that is cortex is breached, and there is extension to the outside. And so but there was, when they suspected it is a case of myeloma or a possibly plasma cell dyscrasia, but there was a hyper gamma globulinemia. But on immunofixation electrophoresis, the amount of M protein was only 0.2 gram per liter. That means it was a case of monoclonal gammopathy of undetermined significance, MGUS, IgA MGUS. And the blood, there was no evidence of CRAB. Other than B, there was no hypercalcemia of the blood, and biochemistry were within normal limits. Bone marrow study from the posterior suprailiac spine, bilateral, were within normal limits. No evidence of myeloma at all, or plasma cell dyscrasia, or any evidence of POEMS. Flow cytometry from the peripheral blood as well as from the bone marrow, there was no evidence, no clue whatsoever to suspect that it is a case of hairy cell. But so when they did not get any diagnosis, they finally went ahead with this biopsy from this left side femoral neck biopsy by the orthopedicians. And on this morphology of this neck biopsy, there is a diffuse sheets of these cells which are strongly positive for annexin A1 and CD20, thus confirming the diagnosis that this is actually a case of hairy cell leukemia present with destructive osteolytic bone lesions in the multifocal sites. And the BRAF 600E was tested from this site, which turned out to be positive, and which was not positive from the peripheral blood or bone marrow. And after this, patient was put on injection cladribine 0.14 milligram per kg for 5 days for 8 weeks, and which led to a dramatic response in the patient symptomatology with reduced uptake metabolic activities on follow-up PET scan at 8 weeks. So it is important that the skeletal involvement or skeletal manifestation in the case of hairy cell leukemia does occur. Up to 3% of cases of, we can expect some cases of unusual presentation in the case of skeletal involvement. Now, as we have seen in our case also, that it is not uncommon to find a diagnosis or define as aplastic anemia with only fat and those very scattered lymphoid cells, which normally we expect in a case of aplastic anemia. But this particular case, when they reviewed the peripheral smear, there was presence of this lymphoid predominance with typical hairy cells. And when they did this CD20, all these things, these interstitial infiltrates of CD20 positive cells were they confirmed, and which also expressed the mutant BRAF B600E this by immunohistochemistry. Thus, it confirmed that it is a case, actually, it's not a case of aplastic anemia. It is actually a case of hairy cell leukemia, which is presenting like aplastic anemia-like presentation, and which was all confirmed with a flow cytometry of the bone marrow aspirate of the lymphoid cells, CD19, CD20 positive lymphoid cells, this 47.36%, this red population, and which is strongly positive for CD25 and 103. Thus, everything confirmed that it is a case of a classic hairy cell leukemia with an unusual morphological presentation mimicking as aplastic anemia. We never expect that this is an exceptional. This is what literature says, that this is called exceptional case report. This is not called as rare case report. That is called as exceptionally exceptional case reports. That hairy cell leukemia is a disease of the adult to elderly patients, does occur also. Full credit to the authors who suspected this case as hairy cell in a child, in a 16-year-old boy who presented with isolated thrombocytopenia with relative lymphoid predominance. Personally, I would have, or we would have considered this case of possibly a ITP, maybe would have been our suspicion, or maybe something things, but we would have never thought in the line of hairy cell. But this patient had no hepatosplenomegaly or lymphadenopathy, and there was no biochemical abnormalities, and but there was 17% atypical lymphocytes with hair-like projections. Hats off to the authors who could pick up such type of hair-like projection in a 16-year-old boy and thinking that it could be hairy cell leukemia. And bone marrow was done that showed CD19, 20, 22, FMC7 expression as well as expression of 103 and 11C. And they did a molecular analysis for BRAF, which came as strongly positive, and that confirms the diagnosis that hairy cell leukemia, that all rare of the rare things does occur in a even exceptionally, and this in a pediatric as well. So pediatric hairy cell leukemia, I don't know when we can diagnose such type of cases. So cutaneous manifestations, there is very peculiar presentations of hairy cell leukemias. This article in Annals of Hematology, recent article in 2021, that leukemia cutis, because these hairy cells, because of this CLA and CCR4 receptors, the chemokine receptors, these hairy cells interact with E-selectin and this CCL17 on the dermal post-capillary venules. That's why they have also a tendency to home towards the epidermis and dermis, and they present as a leukemia cutis. But histologically proven cases of leukemia cutis in hairy cell leukemias are rarely reported. Even this cutaneous skin biopsies rarely shows a positive diagnosis. The diagnostic yield from a skin biopsy is very minimal in a case of leukemia cutis in a hairy cell leukemia. Okay, secondary skin neoplasms, I have mentioned melanoma, non-melanoma skin cancers, like because of the BRAF pathways, and all this have a activated RAS mutation, so they have a bad prognostic things. Even the BRAF inhibition to the inhibitor therapy also leads to activation of this MIKEY signaling pathways, that also is leading to more chance of development of squamous cell carcinoma and melanoma. Also, there is increased prevalence of cutaneous T-cell lymphomas in patients with hairy cell leukemias. They can also have a reactive polyclonal T-cell lymphocytosis, which mimics Sézary syndrome. There are many vasculitic syndromes which may be associated, and in fact, they may precede the diagnosis of hairy cell leukemia. So the cutaneous manifestations should not be overlooked in the case of suspected hairy cell leukemia, because they may precede the actual diagnosis of hairy cell leukemia. It is called as leukocytoclastic vasculitis, polyarteritis nodosa. Paraneoplastic vasculitis can be the initial manifestations of hairy cell leukemia. They can have a neutrophilic dermatosis and infections, last but not the different, all sort of infections. These patients are at risk because of neutropenia. And it is all, remember that infections are the most common cause of morbidity and mortality in hairy cell leukemia patients. So risk stratification in hairy cell leukemia is bad prognostic parameters. We have splenomegaly and leukocytosis with more than 5 into 10 to 9 hairy cells in the peripheral blood, high beta-2 microglobulin 2 times above the normal limit, increased LDH, CD38 co-expression, unmuted, or this is known as wild type immunoglobulin variant things. Wild type has more bad prognosis. And BH434 positive hairy cell leukemia, they also have a high disease burden at the time of diagnosis, poor response to standard therapy, shorter overall survival, and absence of BRAFs, V61s under the mutations. So just, I'm not a clinician, I should not speak much about the clinical management aspect. This is just a thing that this is the latest guideline of the American Journal of Hematology that says that hairy cell leukemia variant first line therapy, and if the patient is asymptomatic, just watch and wait. Wait and watch strategy without any active intervention is what is recommended. Only in symptomatic patients, there is something called as spurin and nucleoside analogs inhibitors, or cladribine plus rituximab. And those which are the variant, which are relapse or refractory, they can have clinical trials. All these things, new drugs are come, ibrutinib, venetoclax, ibrutinib, all these things. And splenic diffuse red bulb cell lymphoma is splenectomy is the treatment of choice, and other cell cycle inhibitors, that is all under trial management. So to summarize my talk on hairy cell, that this is the central cell of today's interest about things, and this hairy cell is actually a result of muted BRAF V600 mutation in the late germinal centers memory B cells. That gives rise to a clonal B cell neoplasm, which has a typical hairy cell morphology because of these intermediate filaments, row family of proteins, and beta-catenin accumulation in the cytoplasm. And these hairy cells, because of lot of integrins, and they have expression of integrins, matrix metalloprotein inhibitors, and they have a special predilection for this or homing towards different organs, like especially the bone marrow and the splenic red pulp, as well as in the skin. There is a down regulation of some chemokine receptors, and in the lymph node, for which lymphadenopathy is not a feature of or is an unusual presentation of hairy cell. And this expression of autocrine mechanism of fibroblastic growth factor transforming growth factor beta produces typical pericellular reticular fibrosis, in contrast to this collagenous fibrosis of other mesenteric positive collagenous fibrosis. Monocytopenia is because of tumor necrosis factor alpha released by these hairy cells. There is this same tumor necrosis factor alpha as well as TGF beta. They suppress trilineage, normal trilineage hematopoiesis is producing the pancytopenia. There is increased risk of second malignancies because of this BRAF and pathways implicated. There is a lot of morphological and immunophenotypic aberrancies that we have already discussed, and that always keeps challenge, they throw challenge on this diagnosis of both flow cytometrist as well as hematopathologist. So we always need to be aware of the aberrancies. There is something called as VCAM interactions, so with this blood vessel endothelial interaction that produces a pseudosinus formation, especially seen in splenic red pulp. There is presence of a lot of red cell, the blood leg formation that occurs in spleen, and there is a possible phenotypic role of a phagocytosis because of the expression of annexin A1. Because these all summarizes with this therapy, not this just minus therapy, summarizes this the typical the hairy cell leukemia things. Now, so this I would like to share this thing that those who are interested, this is an excellent article which has come, annual clinical updates in hematological malignancies, hairy cell leukemia 2022, update on diagnosis, risk stratification and treatment by this Javier Trossard. Yes, this group has and Cornet. So this is an interesting, very useful article which has helped me a lot in understanding this hairy cell leukemia biology. Just to have a next 10 minutes maximum, 10 to 15 minutes, I would like to just quickly go through this large granular lymphocytic leukemia. And before I start that, this is an example of what is known as a large granular lymphocytic leukemia. As the name suggests, this is a large cell which is up to 15 to 18 micron in diameter, and which has a nucleus which is central to eccentrically placed, which has a dense chromatin, mature looking chromatin, no nucleoli, and there is moderate to abundant amount of pale basophilic cytoplasm, and this contains, for which the name is, there are a lot of azurophilic granules. And this azurophilic, because of this name is large granular lymphocytic leukemia. And so first described in 1985, this is a rare chronic mature lymphoproliferative disorders of the T cells and natural killer cells lineage. So we are switching over from a B cell to a T cell which is mature, and the incidence is 2 to 5% in the Western population, and all the T cell neoplasms lesions are more common, relatively more common in Asian continent. They are 5 to 6% Asian continent. There is no gender predilection. This occurs equally in males and females, and majority of the cases are actually indolent. They are called as T large granular lymphocytic, or they may be called as something called as chronic NK cell natural killer cell lymphocytosis that occurs in up to less than 10% of cases. However, so there is a change in terminology, and this is in the 2017. There is a evolution in this classification system of the WHO World Health Organization 2001 mature NKT and NK cell T and NK cell neoplasms, and it was, you can see here that the T cell large granular cell lymphocytic leukemia that has remained constant. Whereas the aggressive NK cell leukemia, there has been a change in the terminologies. In 2001, it was aggressive NK cell leukemia. In 2008, WHO, it was chronic lymphoproliferative disorders of NK cells. Aggressive NK cell leukemia, 2 subtypes was formulated in 2008. In 2016, WHO, there is something called as aggressive NK cell leukemia, chronic lymphoproliferative disorders of the NK natural killer cells, and with a modification, new subtypes recognized with clinico-pathological manifestation, because this type of disorders have a peculiar association, which I am coming next. And there is something called as STAT3 and STAT5B mutations in a subset. This comes under subset classification of NK cell, and this latter is that is STAT5B mutation is associated with a more clinically aggressive disease. Overall, this aggressive NK cell leukemia, that though it is mostly seen in Asian patients, and it is associated with EBV, and this occurs in younger individuals, and this is a more propensity for chemotherapy resistance and refractiveness, and it is universally fatal, and because of this refractiveness to this chemotherapy, this aggressive NK cell leukemia. So this clinical biological behavior of this large granular lymphocytic leukemia is quite diverse, and though this in contrast to an hairy cell leukemias, this occurs over a relatively wider age range group, though the median age is more than 50 years for large granular lymphocytic leukemia, but up to 25% cases occurs in less than 50 years also. So this does tend to occur in a younger population also. We can expect this type of lesion in younger age group. Fatigue and B symptoms are not that common. Up to 20% of cases they are reported. Splenomegaly is up to 50%. Lymphadenopathy is rare, like hairy cell leukemia. Neutropenia associated in a manifestation like oral or oropharyngeal infections, fever, and this is more common in these conditions. That in fact there may be this initial manifestation of this type of lesions. But interesting thing is that this condition is associated with an autoimmune cytopenias in the form of autoimmune hemolytic anemia, ITP, immune thrombocytopenic purpura, Evans syndrome combined autoimmune hemolytic anemia and immune thrombocytopenic purpura, Evans, or even pure red cell aplasia, PRC. And 30% of patients are transfusion dependent anemia, and lymphocytosis in large granular lymphocytic leukemia can reach up to 6,000 per cubic millimeter, 6 into 10 to 9 per liter. And there is up to 70% of patients have a significantly raised beta 2 microglobulin. And more important feature of association is that 60% had a associated rheumatoid arthritis factor. RA factor is positive, 40% is anti-nuclear antibody positive, and polyclonal hypergammaglobulinemia is more common. And this group of lesions are more commonly associated with very autoimmune diseases. Most common of this is rheumatoid arthritis. And also, interesting, though it is a T cell lesion, NK cell lesion, but they are also associated with even this MDS, paroxysmal nocturnal hemoglobinuria, aplastic anemias, as well as myeloid malignancies, and even B cell lymphoproliferative neoplasm like hairy cell leukemia. So, a B cell lymphoma leukemia is associated with a large granular lymphocytic leukemia. This is the funniest part of this biological association of this group of lesions. So the mechanism of this pathophysiology of this condition is that there is a close interaction between different things. But there is a chronic inflammation, there is a state of chronic inflammation, there is a state of autoimmunity, there is B cell malignancy, lymphoid malignancies, AML, as well as myelodysplastic syndrome, as well as some viral infections and some unknown factors. All this, there is a close interplay of this type of interaction that lead to some stimulation, something called as leads to something called as antigenic stimulation of effector memory cytotoxic T cells. Hairy cell was post germinal center memory B cells, whereas this is stimulation of effector memory cytotoxic T cells. I repeat, cytotoxic T cells, not the helper T cells. So these are actually cytotoxic T cells, and that leads to something called as activation of this Janus activating kinase STAT3 pathway, and this gives rise to more activation of something called as survival advantage pathway. There is a resistance to the fast ligand mediated apoptosis. So there is resistance to the apoptosis, that is more survival. Also RAS, RAP, MIKEY, ARK pathway activation, nuclear factor kappa beta pathways. So all these things leads to final stage of clonal lymphoproliferative neoplasm of large granular lymphocytic leukemias. So the diagnosis is that there has to be an expanded population of clonal large granular lymphocytes present in the circulating in the peripheral blood or in the bone marrow. In the bone marrow, at least 10% of these cells, clonal cells, is sufficient to call it is a large granular lymphocytic leukemia. 10% is enough. Previously, there was the criteria was 2 into 10 to a 9, like plasma cell leukemia. So this previously this side that was 2 into 10 to a 9, 2000 cells of large granular lymphocytes in the peripheral blood. But nowadays this cutoff has been more reduced. There is a clonal large granular lymphocytes less than 1000 also, but if it is associated with clinical manifestations like rheumatoid arthritis or cytopenia or typical morphology, it has to be considered with suspicion and further evaluated. This is the typical large granular lymphocyte in a circulating peripheral blood, and this is in the bone marrow aspirate films of a case of large granular lymphocytic leukemia. So the immunophenotypic characteristic is, as I said, it is a cytotoxic T lymphocytes. They have something called as mature post-thymic phenotype, and which is CD3 positive, TCR alpha beta positive, CD5 DIN, CD8 positive, CD16 positive, 27 negative, 28 negative, and 57 positive. But if these patients have, they co-express CD56, predominantly T granular large granular lymphocytic leukemia, if it co-expresses CD56, that is an aggressive entity which is usually associated with STAT5B mutated with a worse prognosis. There are some rare sporadic reports that even the T large granular lymphocytic leukemia can have a co-expression of CD4 and CD8, and if this occurs, they're never present with cytopenia, autoimmune manifestations is never seen, and they do not present with splenomegaly. Whereas the NK cell large granular lymphocytic leukemia and this NK large granular lymphocytic leukemia lymphocytosis is CD2 positive, surface CD3 negative, TCR alpha beta negative, CD8 positive, 16 positive, and 56 negative. So this is what is the feature of, you can see that this is a flow cytometric scatter plot of T large granular lymphocytic leukemia. You can see that this is CD4 positive population of cells. CD4 is this, and this is the cell of interest. Green ones are the cell of interest. That is yours CD8 positive cells, CD3 positive cells. This is green population, 66.05%, and this is expressing CD8 and CD5. Weak CD5 or dim CD5 and strong CD8. So this is example of a T large granular lymphocytic leukemia. And the lower panel is the natural killer cells large granular leukemia. You have this CD3 versus, and this is negative for CD3, you can see here, and this is negative for CD4 and 8, and you have CD16 is strongly positive, okay, CD16 41%, CD5 negative, and you have CD56 variable, and CD3 negative. So all these things are that it is a NK cell origin. So personally, I have never seen a case of such entity till now. This is such a rare, maybe we might have missed. But overall, the approach should be that what the authors have said, that when in a patient present with neutropenia-related infections and manifestations, where there is lymphocytosis, and especially if there is an autoimmune disease like rheumatoid arthritis is present and associated autoimmune manifestations, peripheral blood smear evaluation, meticulous peripheral blood smear evaluation must be done for finding of an suspicious or large granular lymphocytes, as I have described. And then we have to go for a flow cytometry to see that whether it is T or NK type. And the definitive thing has to be that there has to be a clonality has to be proven, that it is clonal, or that means of T cell receptor gamma rearrangement, and STAT3 mutation status as per the WHO classification. If it turns out to be polyclonal, then that means it is reactive. That means if the GN rearrangement studies are negative, then it is polyclonal T cell NK cell activation, which is most commonly likely to be post-splenectomy. Viral infections like infectious mononucleosis, CMV, HIV, and post-transplant conditions has to be most likely. If it is a gray zone, there is a borderline result of whether it is polyclonal, query-clonal, then it's a gray zone. In those cases, there is an indication of doing a bone marrow evaluation, bone marrow biopsy, where these cells are likely to be present in an interstitial or intravascular pattern, and we have to do a CD3, CD8, and granzyme and TIA1 IHC for characterization, and then we have to go for true studies for true clonal expansion. So this is with this, I come to an end of this my today's presentation on hairy cell leukemia and large granular lymphocytic leukemia. And I would like to once again thank Pursue this Nilam's pathology lecture series, Dr. Nadeem sir, Dr. Deepak Mishra sir, and my senior colleagues, my mentors, respected faculty members. And this is where I work presently. This is the wonderful All India Institute of Medical Sciences, Bhubaneswar, during evening hours, well lighted up, and during Independence Day time. And it's fantastic to work here with so much of fabulous and wonderful colleagues. He's Dr. Gaurav, who is sitting right to me. He looks after this flow. And many of my faculty colleagues, they look after this lymph node pathology, where we always cross-talk between mantle cell or cyclin D1 positive hairy cell. And so we have a fantastic team of doctors and staffs which to support. And last but not least, it is the clinicians who always trust on us for our diagnostic approach. And we are always grateful to our patients who always inspire us, who always provide us the valuable material, they keep us throwing challenge. That's how we always learn from our patients. So it's a rich tribute to my patients. And thank you so much, everyone, for your patient hearing. Thank you.
Thank you so much, sir. An extraordinary presentation. Very, very, very nicely done. Excellent. Brilliant presentation, both on the LGL front as well as on the hairy cell front. Very nicely presented. And we cherished your experience on the hairy cell. My God, very nice experience and very in-depth knowledge of hairy cell leukemia. Wonderful. And the articles which you showed us and some of the rare cases which you showed, especially the hairy cell in the child, yes, it needs a lot of guts to diagnose that, yes. And you are right, anybody in our setup would be thinking of an IATP or something like that. That's true. Wonderful presentation, and I think everybody across who will be listening to this lecture subsequently will really benefit from this. Thank you for sharing the PDF as well as the PPT. We'll be uploading the PDF on the Google Drive. And we'll be having you again for 2 more lectures. It will be an honor to host you, sir. Wonderful presentation. Your knowledge is very good. And your presentation is super, very nicely done. Thank you so much. God bless you. Take care. Bye-bye.
Thank you, sir. Thank you so much, everyone. Thank you so much.
Thank you. Bye.